Bismillahirrahmanirrahim. Assalamu alaikum and welcome to today's journal club. The study is today's study is going to be presented by Dr. Durre Shohab. He's a consultant urologist, Maruf International Hospital. It's an observational study. The topic is exploring relationships of catheter-associated urinary tract infections and blockage in people with long-term indwelling urinary catheters. So please.
Bismillahirrahmanirrahim. I'm Dr. Durre Shohab and I'm going to present a study with the title of Exploring the Relationships of Catheter-Associated Urinary Infection and Blockage in the people with a long-term indwelling catheter. Okay. So how common this thing is, and what we will call a long-term indwelling catheter. So these long-term indwelling catheter, they are used in the people with limited mobility, disability, and who are not able, and when there is no other way of draining the bladder, like self-catheterization, like we don't want to make a pouch. When we don't have any way to drain the bladder, then we need to put a catheter. And that may be long-term, that may be short-term, depending upon the condition of the patient. The exact prevalence is not known, but in the US National Center for Health Statistics, they reported for the incontinence, they found that 13% of the population they studied, they had got this long-term indwelling catheter. Similarly, in the end of life hospice discharges, this percentage is almost 38%. So this indicates that there's quite a significant proportion of the elderly people, even the young people with different diseases who have this catheter, and this catheter is maybe there for years and years. The main problem about why we don't know the exact prevalence is most of the study, they do not differentiate between the long-term catheter, maybe that is the catheter which is there for more than a year, or a short-term catheterization. Even in some studies, the condom catheter, they consider that the patient is catheterized. So here we are talking about long-term indwelling catheter. So whenever there is the long-term indwelling catheter, the three main issues that a patient suffers, they are catheter-associated UTI, blockage, dislodgement of the catheter, and other issues like sedimentation, like bladder spasm, pain related to the catheter, episodes of hematuria, and all those. So this study, it is actually a secondary analysis from a randomized control trial with the title of Self-Management Intervention for the long-term urinary catheter. This was a trial in which the people having a long-term catheter, they were divided into two groups. One group received the usual medical care, and while the other group, it received, they were trained, they were taught how to manage their catheter by themselves. So there are the detail I'm going to show you in the next few slides. So the data, it was collected from the 6 bi-monthly interviews over 1 year. It was conducted over 12 months. Total 998 interviews were there from 193 patients. And about 75% of the patients, they were able to complete the full 12 months of the study. So the aim of current study, it was to know what are the primary and secondary catheter-related problems, to explore the relationship between the catheter-associated UTI and blockage in relation to the demographic, secondary catheter problem, and the catheter care practices. What are the different catheter care practices, and does this catheter lead to the excess healthcare utilization in the people? So it was in the parent study, there were 202 patients that were recruited. From the two sites, one screening, it took place on the phone at the university site, and the second one, it was a home care agency They were basically the source of these patients. The patients with poor life expectancy, cognitive, behavioral, or hearing problems, they were excluded. The inclusion criteria, these are the people who need to use this catheter at least for a year, who have access to the phone, and they plan to live in the region for at least 4 months, because this was the time when they are going to, it was for basically for the parent ICT. This was the time when the patient were given intervention, that is the home care visits by the nurses. So, and the patient, the ethical approval was taken. We all know this is. So the patient who received intervention, there were 3 home visits by the trained healthcare visit workers, 2 in the first month, phone call 2 weeks later, and a final visit at the 4th month. And during this time, the patients, they were taught how to, about the fluid intake, about the positioning of the catheter, about the irrigation required, when to call the doctor, and those things. The control group, it received the usual care by their doctor or their caregiver as it was before. So basically, the 4 instruments they were designed. The first was the demographic questionnaire that includes the patient age, gender, type of the disease for which he is catheterized, for the period of time he is being catheterized. The catheter care questionnaire includes the questions like whether the catheter was irrigated, what was the size of the catheter, was it a urethral catheter or a suprapubic catheter, what was the volume of the water in the balloon. The catheter problem questionnaire addresses the UTIs, blockage, spasm, pericath leak, sedimentation, and all those things. So for this, the data, it was collected, basically, they review the record of the 2 monthly interviews conducted over the 12th month, and they collect the data regarding the variables I'm going to show in the following slides. So the data was collected regarding blockage, catheter-associated UTIs, sedimentation amount, catheter leak and bladder spasm frequency, and the level of disability as it increases with time. Importantly, the one important point here is to define the catheter-associated UTI. Pyuria is not a sign, is not the indication that the patient has got a urinary tract infection. A culture showing any the germ is not indicative that this patient has got catheter-associated UTI. So it's a combination of a organism grown on the culture plus a symptoms should be there, and these symptoms in the chronic in the patient with the chronic indwelling catheter, they will be different. They may not feel a bladder pain. They may not feel they may not feel urgency, frequency, all those things. So the most important factor is the altered mental status. The patient is catheterized, he start taking, his feet become poor, he is not able to comprehend, he is not able to talk. This may be a UTI. The patient start the pain in the flanks, patient develop high-grade fever. This may be a UTI. And importantly, whenever we see that something is coming out of the ureter, that is like some odorous or urine, that is not the indicative of the infection. These are the symptoms plus our organism growing on the culture, then we can label the person is having a UTI. Urine sediment amount, it was, they call the patient and they give it a number. They said that, okay, if there is no sediment, they give it a 0 score. And if there were a lot of sediment, then they call it, the score was given as 5. And similarly in between. Similarly, the size of the sediment, it was just a powder, score 1. If it was a large fragment, then they gave it a score of 5. Catheter leakage and bladder spasm frequency. Each patient, he was given a diary. And in diary, they were asked to just mention the problem they are having and each problem was given a simple code. Like if there was leakage, they just need to write L. If there is spasm, they just need to write S. And after 2 months, there was a call, and the patient report that in past 2 months, he has got this much problem with the catheter. So these are the patient included in the study. We can see the majority of the patient, majority of the patient, they had got spinal cord injury followed by multiple sclerosis, diabetes, 20 patients with the prostates, 16 patients having neurogenic bladder. So these are actually the characteristics from the parent study. The mean age, it was 60 years. The mean duration of the catheter, it was 73 months. Most of the patients, they have got catheter size of 18 French, 53%, 53 in one and 15 other group, they were male. At baseline, most of the people, they have got urethral catheter, 43% have got suprapubic catheter. Most of the people have got 65 to 10 ml of water in the balloon. And this is quite strange because 30 ml is indicated only in the post-operative periods. So what they found that 57% of the patient, they develop catheter-associated UTI, detail to follow. 34% of the people, they develop blockage, and 28% of the people, they develop dislodge. These are the number of episodes. This is the percentage of the patient. These are the number of episodes. So 507 blockage episodes and 34% of the patient. Here comes the concept of frequent blockers and non-blockers. The important thing is each and every person is different. Each and every patient is different. And there is no single stick with which we can treat, single medicine or single way that we can treat all the patients. So I think Dr. Mustafa and Dr. Mobeen are here. They are going to better guide us. So we can see that the catheter-associated UTI, in the patient with the catheter-associated UTI, the odd ratio of having blockage, it was 1.52, and it was statistically significant. So whenever the UTI was there, there was a higher chance that the blockage is there. Similarly, leakage, pericath leak is associated with UTI. It may not cause, but whenever there were UTI, there was some pericath leak. Similarly, the blockage also has got association with the pericath leak. Kinks and twists, most of the time we tell them that they may be the cause, but we can see that they are not related to, neither related to UTI nor related to block. Most probably because they are not present all the way, the patient is changing position all the time. Bladder spasm, significantly related to the UTI. Catheter-related pain, strangely, the spasms were related to UTI, but pain, it was not related to the UTI. It was the catheter-associated pain that patient is not tolerating the catheter. Sedimentation, these are the sediment frequency. If the patient is having the daily sedimentation, sediment have got no direct link with the catheter-associated UTI. However, it was associated with the blockage. Sediment amount, larger the sediment amount, more chances of UTI, more is the UTI, more is the blockage. One of the reasons for this, that Proteus mirabilis, that is one of the urine-excreting organism, it leads to the formation of the biofilm and incrustation that leads to the larger fragment, therefore that increases the risk of the catheter-associated UTI. The catheter size, balloon size, irrigation, they have got no association, no relation to the catheter-associated UTI. However, irrigation was associated with blockage. Here I'm not, again I'm saying this is, I'm not telling about causation. This is not causing, this is just related. There may be a factor that there is blockage, that's why the catheter was irrigated. Or similarly, we can see the irrigation frequency. More irrigation frequency, more chances of blockage, maybe, or more blockage, more irrigation. Whenever the patient, it was irrigated for the problems, there was a significantly high relation with the catheter-associated UTI and the blockage, because the most likely reason is that it was irrigated because the patient was having some issues and like the blockage of the catheter and those things. So here we can see that what were the characteristics of the patient at the baseline and at the 12th month. We can see there was a slight decline from urethral catheter to in the use of the urethral catheter. Suprapubic catheter, there was gradually more and more people, they were opted for the suprapubic catheter. Catheter size, it was the smaller catheter over the period of 1 year, the use declined and compared to the larger catheter. This is a strange finding because most of the time, using the larger catheter, there is the concept of plugging the leak and better drainage. The smaller the catheter, it leads to block again and again. But the larger catheter irritate a bladder more because it can irritate the sphincter, that can lead to the increased frequency of the pericath leak. Balloon size, the strange thing is that still at 1 year, some people, they were using 30 ml of a balloon. That may be the reason. There may be a patulous urethra, smaller balloon may be coming out, but 30 ml is too much of water in my view. Okay, we can see that sediments, they were small sediments, they were almost the same over 1 year. Larger segments were becoming less over the period of time, probably because of the better management of the catheter. Similarly, the sediment frequency, it was the same. The larger segment frequency, it was reducing. Overall, all this over the period of 1 year, the sedimentation and the frequency, it was getting less and less. Probably it may be due to the patient getting better management of the catheter. So this is important, that the difficulty in the insertion and removal, initially difficulty and pain. So that whenever the catheter was changed 1 or twice in the month, most of the patient, they feel the pain. Insertion was more painful compared to the withdrawal. And initially, most of the people, they rate the insertion, the difficulty rating of 54, that declined over the 12th month to the 44. Catheter pain was related to the positioning, initially 45% people, but later it became better. The bladder spasm, they increases over the 1 year time. Most after the period of 1 year, most of the patient, they started to feel pain all the time. And we can see that over the period of 1 year, initially the catheter was bothering many patients to a great deal, but it gradually reduces over the period of time. And similarly, the little discomfort, it was getting more. So it is a way that patient, they were getting used to their catheter. Importantly, because it's a retrospective analysis, most of the data, it was collected through the telephonic details. So obviously, the amount of the data that we have received, that may not be very much accurate, but these give us a good idea that how a person with a long-term catheter behave over a period of 1 year time. These are the excess healthcare utilization option reported. We can see that in case of the UTI, 110 patient and total 268 episode, 50% required extra nurse home visit, extra office visit, 73 people, 155 catheter were changed, 267 people, they were given the antibiotics. For the blockage, we can see the catheter 55 out of 66, 55 catheter would need to be changed, and that lead to the extra burden regarding the either home visit or the office visit. Okay. So if we let's come to a bit of the discussion, and after that I'm going to open a session for the debate. A lot of the people are living long life compared to before, and the people in their later ages of life, they sometimes require a long-term catheter. So in this study, we have found that the catheter-associated UTI and blockage, they are related to the spasm, sedimentation, catheter-related pain. The catheter-related pain, difficulty with insertion, removal of bladder spasms, all they become better over a period of time. However, we need to deal, like catheter-related pain, we need to know what is causing the pain. Is the patient allergic to the latex, or the patient has some problem in the positioning? If he has got a uterine catheter, we can change it to the suprapubic one. Difficulty in the insertion and removal. Most of the studies, they reported only when there was a traumatic catheterization. Here, it's the patient perspective when you think that there was the difficulty in the insertion of the catheter or removal. The bladder spasm, we need to rule out that whether these spasms, they are secondary to the UTI, or it is just the irritation of the bladder. It may also be related to the primary disease of the patient, like the neurogenic bladder. The patient may need some antispasmodic medication. Catheter characteristics, most of the time the catheter used, it was the 18 French catheter. Suprapubic, there was a gradual trend toward the suprapubic catheter. Suprapubic catheter is better in preventing the urethral fistulas, urethritis, prostatitis. But overall risk of the UTIs after using a suprapubic catheter is same in the urethral versus suprapubic catheter. The risk of pyelonephritis and cystitis, they are not changed by using a suprapubic catheter. Sedimentation and irrigation. The irrigation, most of the time, is of no use in preventing the UTIs or preventing the blockage. Because we need, there was a Canadian study in which the people, they were labeled into the two groups. One group received the irrigation with the ranitidine, the other group received the saline irrigation, and the third group received no irrigation. The blockage and rate of the change of the catheter was same in all the three groups. And excess healthcare utilization related to the catheter-associated UTI and the blockage, we have already seen that these two factors have led to the increased visits as well as increase the healthcare budget of the patient as well as support. So I think this is not, there is no conclusion to this topic, because we need to know more. We need to do a better study in a prospective way so that we can know not only what are the catheter-associated problems, but also how to treat them. Because there are a lot of guidelines now that are in place that I think I would be able to answer the question, and that's why I just left the conclusion segment. So I open the house for the debate. For any question, I'm willing to answer that.
I think it's an article, isn't it?
It's an article. Sir.
What is the conclusion in the article you want to
The article, they said that there is definitely an association between the catheter-associated UTI, blockage, spasm, sedimentation. But that is not a causation, because this study is not a case controlled study, or it is not an RCT. So there is an association, but we cannot label them as a cause. Like sediment. Sediment may be the result of a UTI from the protease, or sediment leading to blockage leading to the retention and the mucosa that can lead to the UTI. Therefore, there is these are the problems. Like any patient who is having a chronic indwelling catheter will be having the increased risk of the UTIs, blockage, spasm, frequency. They have got association, but we need a better study to see that what is the cause and what is the effect. Actually, I was hoping for a lot of questions. A few take-home messages I just want to give. And these are actually from the Brits guidelines and all those. Number one, tell the patient that catheter is not the end of all the problems. This is end of one problem, but you may have got risk of, you are on increased risk of UTI. You can have this blockage of the catheter. You need a suprapubic catheter if you're a male patient, because it is going to decrease the risk of the prostatitis and urethritis, but it is not going to prevent the overall risk of pyelonephritis or the UTI, number one. Number two, we don't know that what will be the changing frequency of the catheter. If you're blocking it early, we may need to change it every 2 weeks. If we may need to change it every week, and we may have to, we can keep it over the 2 months. So we don't guarantee you that if this is a silicone catheter or this is a latex catheter, so this is better, this is not better. Because if you are having a latex catheter and you are not blocking it, you can keep it for a month. And if you have got silicone catheter blocking, every 1 week you need to change it. Number three, we are not going to treat you for pyuria, malodorous urine, or any organism growing in the urine without any symptoms. Because sometimes the patient, they are coming with a report that I have got, that this patient has got a positive culture. Do we need to treat it? No, we do not need to treat them. And importantly, catheter versus no catheter, if we are not putting a catheter, the patient will go into retention, the patient will develop pyelonephritis, the patient will develop septicemia. So sometimes the drainage of the bladder is necessary. The type of the catheter, it all depends upon the condition of the patient. Important thing, prophylaxis, the last thing. The prophylaxis prevent from the life-threatening complication like pyelonephritis, but it is not recommended in all the patients. A patient is having recurrent UTIs, and you can use, so every patient with a catheter doesn't require a prophylaxis. It will just increase the resistance of the drugs.
Sir, it's related to the study design. In an observational study, do we still talk about validity in an observational study? Because in this study, most of the information was gathered through a questionnaire. It was all subjective based on the participants' response. So do we still discuss validity in this kind of study design?
The simple answer is yes. Any study, any research study, be it a single arm or double arm or a prospective or a retrospective, that has to go through the process of validation. So validation criteria can vary. For example, a case control is an observational study has a different set of criteria. Cohort studies and observational study has a different set of criteria. Or cross-sectional study, maybe an observational study can have a different set of criteria. It all depends that the question that you are asking, two, the context in which you are asking, and three, is that the right way of addressing that particular question? So whenever you are putting all these things in context, so it has to go through the process of validation. For example,
how would we say the study is valid?
Yeah. जो मुझे समझ में आता है स्टडी से थोड़ा सा वो it seems like people who have long standing indwelling catheters, they are trying to study the prognostic implications. They are trying to figure out what percentage of people are getting leaks, etc. And then they are trying to figure out what particular factors are associated with infection. वो associations बनाने, तो उसमें blockage की बात करते हैं, उसमें कोई sediment की बात करते हैं, या कोई और चीज़ों की बात करते हैं. तो prognostic study की validation बिल्कुल होती है, लेकिन किसी और तरीके से होती है. और जैसे उन्होंने बिल्कुल सही कहा डॉक्टर दुर्रे शाह ने कि the best study design for prognostic study is prospective. One, secondly, उसको हम एक inception cohort कहते हैं. Inception cohort, for example, किसी को आज अगर पेशेंट को इंटरवेलिक कैथेटर डाला और हमने इसको प्रोस्पेक्टिवली फॉलो करना शुरू कर दिया, तो आज का पेशेंट जो होगा दैट विल बी इंक्लूडेड, नॉट द वन व्हिच वाज 20 डेज अगो. तो इस तरह से आप एक प्रोस्पेक्टिव कोहॉर्ट क्रिएट करते हैं. तो दे आर द बेस्ट, दैट्स द बेस्ट वे, दैट्स द वैलिडेशन की आप बात कर रही हैं, वो डिजाइन सबसे अच्छा काम करता है. यहाँ पर जो लिमिटेशन ये थी कि एक और रैंडमाइज्ड कंट्रोल ट्रायल का डेटा था और उन पेशेंट्स का के पास इंफॉर्मेशन होगी और उन्होंने बाद में सोचा होगा कि चले इनसे हम ये बातें पूछ सकते हैं। अच्छा, मतलब की बात ये है कि इसी स्टडी को शायद किसी केस कंट्रोल फॉरवर्ड के तौर पे भी किया जा सकता था, या अगर इन्होंने रेट्रोस्पेक्टिव कोहॉर्ट किया और उसको फिर सामने लेकर के आए करने की, वो भी कर सकते थे। लेकिन ठीक है, मतलब वो that's the way it is done. It seems like it is like more of a prognostic implications उसके अंदर embedded है कि क्या वो हम association figure out करें।
हाँ जी प्लीज।
ये वही क्वेश्चन, फर्स्ट क्वेश्चन, आर द रिजल्ट्स ऑफ द स्टडी वैलिड? इंटरनल वैलिडिटी की बात है। आई थिंक द रिजल्ट्स क्वेश्चन है कि बेस थे तो सही प्रोग्नोस्टिक स्टडी वाला प्रोग्नोस्टिक आर द रिजल्ट्स ऑफ द स्टडी वैलिड से यही बात ही वैलिडिटी बेस तो आई थिंक
पढ़ेंगे ना, बोलो कि एक्सेप्शन कोहॉर्ट में लिखा हुआ है।
So यहाँ it is preferable if study patients are enrolled at a uniformly early time in the disease, usually when disease first becomes manifest. Such groups of patients are called an inception cohort. Patients should also be representative of the underlying population. Patients from tertiary referral centers may have more advanced disease and poor prognosis than the patients from primary care.
For example, किसी को cord injury है, अगर they are enrolled at different points in time, so you won't be able to get valid results. उसको मतलब है कि आपने start करा और prospectively जो आता गया उसको देखते गए। Classical ऐसा होना चाहिए, जिसको जैसा नहीं कह रहा था, लेकिन बात दफा ऐसा नहीं कर सकते। फिर आप retrospective cohort, अगर आप पुरानी सारी को पहली दफा डाला था catheter, तो retrospective inception cohort भी हो सकता है।
So, इसमें इन्होंने RCT से जो लिया था तो वो at the point of catheterization उन्होंने डेटा स्टार्ट किया था।
मतलब इसके अंदर the patient they were enrolled, but the problem was उसके अंदर वो तमाम patient enrolled हुए थे कि जिनको कैथेटर कुछ को 3 महीने पहले पड़ा है, कुछ को 6 महीने पहले पड़ा है, कुछ को 1 साल पहले पड़ा है। So it was basically all the patients they were enrolled at one time, but the detail कि उनको कैथेटर कब से पड़ा हुआ है, it was not provided in the primary RCT as well.
So मेरे साथ मैं तो उसको अनक्लियर में भी रखूँ यहाँ या इसको वैलिडिटीज की। Was patient follow up sufficiently long and complete? 2 years?
1 year time.
1 year time था। तो और उससे पहले हमें ये नहीं पता कि प्रीवियसली वो कितने अरसे से कैथेटराइज थे। अभी 78 मंथ्स था, बिल्कुल 73 मंथ्स। पहले से लगा हुआ होगा किस पॉइंट, शायद सर इसमें भी शायद हमारे लिए क्वेश्चन were outcome criteria either objective or applied in a blind fashion? Outcome तो इसमें हमने ऐसे डिस्कस नहीं की, it was just an association.
Outcomes were determined by the patient. So you have given a questionnaire to a patient that जब आपके पास आपको पेन होना शुरू हुआ, हाँ या नहीं, मरीज ने जवाब देना, तो वो अपना आउटकम खुद डिटरमिन कर रहा है, राइट? यहाँ पर ब्लैंडेड आउटकम तो नहीं है, लेकिन पेशेंट अपना आउटकम खुद डिटरमिन कर रहा है। यू कैन क्वेश्चन कि वो ऑब्जेक्टिवली पेन को तो हमेशा पेशेंट का है,
ऑब्जेक्टिव तो सब्जेक्टिव एक्चुअली,
यहाँ पे कुछ जगह पे ऑब्जेक्टिविटी नहीं आती, और प्लस पेशेंट जब पेशेंट को पेन होनी है दूसरी ने बताना है कि पेन होनी है, तो वो दैट बिकम्स अ वैलिड क्राइटेरिया। लेकिन सीम्स लाइक इट बहुत सारे जो आउटकम्स हैं, हाँ इन्फेक्शन डिटरमिन कैसे हुआ वो किसी और ने करना था, बस इक्वलाई ग्रो करता है और पेशेंट ने कहा मुझे स्पाज़म हो रहे हैं, और किसी थर्ड पर्सन ने कहा क्योंकि ये सिम्पटम्स और दोनों चीजें हैं तो ये इन्फेक्शन है, तो यूटीआई डिटरमिन, तो that determination was done by a physician or whatever, किसने level किया हमें नहीं पता.
If subgroups for different with different prognosis are identified, did adjustment for important prognosis? Sorry, मैं ये study पे apply नहीं करता ये part. What are the results? The results we saw that
there was association between the Cath-Associated UTI, blockage, sedimentation. There was no association between the catheter size, type of the catheter, amount of urine, amount of water in the loon, and irrigation.
There was just an association or causation establish करने के लिए हमें फिर
No causation, association.
associate तो उसके लिए हमें कर we need a better study to establish the causation. Okay.
Yeah, उसमें तो ये होता है कि you need to have some kind of a comparison association.
बिल्कुल comparison.
जब भी आपने odds ratio निकालना है, odds ratio is going to come odds का बारे में थोड़ा सा बता दो. For example, आपने कहा कि आज बारिश होने के कितने odds हैं? तो कोई कहता है कि 1 out of 10. These are odds. This is not a ratio. इस्लामाबाद और लाहौर में बारिश होने के कितने odds? इस्लामाबाद के 1 in 10 है, लाहौर के 2 in 10 है, whatever. जब मैं इन दोनों को डिवाइड करूंगा, only then it will become an odds. So that is why whenever you say association in terms of odds ratio, it has to have two groups. That will give you odds. एक ग्रुप से सिर्फ odds.
तो 2/2 का जो टेबल है वो और रेशियो डिटरमिन करता है कि और
रिलेटिव रिस्क भी कर सकता है और रेशियो भी कर सकता है. डिपेंड करता है कि स्टडी डिजाइन क्या है. केस कंट्रोल में सिर्फ और रेशियो आती है, रिलेटिव रिस्क नहीं आ सकता. कोहॉर्ट डिजाइन में और रेशियो भी आ सकती है, रिलेटिव रिस्क भी आ सकता है. रैंडमाइज्ड कंट्रोल ट्रायल में और रेशियो भी आ सकती है और रिलेटिव रिस्क भी आ सकती है.
So यहाँ पे हमने जो odds ratio निकाली है उसमें मैं प्रोसेस कोई वेल डिफाइंड कंट्रोल ग्रुप तो नहीं था.
अब मुझे नहीं पता कैसे निकाली. वो पता कैसे निकाली है? आउटकम ऑफ इंटरेस्ट किया जो कि था यूजर और उसको रिग्रेस किया और पॉसिबल 5-6 चीजों के साथ. जब उसको रिग्रेस किया, रिग्रेशन अक्सर उन्होंने रिग्रेशन किया होगा जी मल्टी वेरिएबल. तो उन्होंने देखने के लिए कि यूटीआई का किन पर्टिकुलर फैक्टर्स के साथ कोई एसोसिएशन बनता है. तो रिग्रेशन एनालिसिस में उन्होंने 3 या 4 चीजें दी होंगी. अब वो कैसी मॉडलिंग कैसे हुई थी मुझे नहीं पता, अनफॉर्चुनेटली मैंने इसकी मेथोडोलॉजी नहीं पढ़ सका. तो लगता है कि ये इस तरीके से और उन्होंने कहा कि एसोसिएशन 3 चीजें पॉजिटिव आई पी वैल्यू सो कॉल्ड लेस देन 0.5. 3 चीजें माइट बी टर्म, लेकिन ये नहीं पता कि ये सिंपल रिग्रेशन था. ये सिंपल रिग्रेशन करने के बाद जो सिग्निफिकेंट आए थे उनको मॉडल में डाला गया, जैसे बैकवर्ड भी हो सकता है, प्रोस्पेक्टिव फॉरवर्ड भी हो सकता है, बहुत सारी मॉडलिंग. तो वो मुझे पढ़ना पड़ेगा, मैंने नहीं पढ़ा.
सर वो यही है जो आप कह रहे हैं मल्टीलीनियर
सर
मल्टी वेरिएबल लीनियर रिग्रेशन के थ्रू हो गया. और मतलब दे हैव एडेड द वेरिएबल्स, मतलब कुछ को उन्होंने वो किया कि मल्टी उसके साथ हो. और सेकेंडली देन कोई चीज आई डोंट नो जीरो इन्फ्लेटेड वो क्या है. So it was a alien language for me.
लेकिन लगता है ये रिग्रेशन है.
सर डॉक्टर मुश्तबा कादी से ये
मुझे तो कुछ एक्सपर्टीज तो नहीं रह सकता इसमें, लेकिन कुछ जनरल कमेंट्स अगर कर दें तो आई थिंक रीजनेबल होगा. So Bismillahirrahmanirrahim. First of all, thank you, Dr. Durre Shohab. I think not easy to look at somebody else's secondary analysis of post hoc analysis of original study. In any case, लेकिन हमारे ज़हन में ज़रूर क्लियर होना चाहिए कि what are the study questions we are trying to answer and what the paper is trying to answer. And again, I also apologize, like Dr. Babin, मैं भी इसको पढ़ नहीं सका इस पेपर को पहले, तो इसलिए वो अभी सुबह कॉफ़ी भी काम नहीं कर रही, तो समझ नहीं आ रहा है कि इतने सारे टेबल्स आए ना, इतने टेबल्स आए, इतने फिगर्स आए कि it has just gone went in and has clogged me completely. But all I can come out with from the tables and other things is कि देखिए ओरिजिनली कोई भी कोई randomized control trial करे ना, तो उसके अंदर एक अच्छी अपॉर्चुनिटी होती है सब्सिक्वेंटली अगर कोई अनआंसर्ड क्वेश्चंस हों तो पीपल कैन डू अ सेकेंडरी एनालिसिस एंड उसके अंदर रैंडमाइज्ड कंट्रोल ट्रायल में जो लिम जो एक्टिव लिम पे थी और या इवन जो दूसरी थी उसके अंदर आप एम्बेड कर सकते हैं वेरियस फॉर्म्स ऑफ ऑब्जर्वेशनल डिजाइंस. So you can nest things in there, you can nest case control studies in there, you can nest cohort studies in there, you can nest retrospective, prospective cohorts in there. तो उसके जरिए आप कुछ फर्दर कुछ एसोसिएशन आएंगे और जहाँ पे आप ऑब्जर्वेशनल स्टडीज में आ जाते हैं वहाँ पे सिर्फ एसोसिएशन आप दिखा सकते हैं. क्योंकि उसके अंदर जो है इशू आता है कि लैक ऑफ रैंडमाइजेशन की वजह से नोन एंड अननोन कंफाउंडर्स आर नॉट बैलेंस्ड। सो बड़ा मसला हो जाता है कि एसोसिएशन ट्रू है या कंफाउंडेड एसोसिएशन है। इसलिए जो भी एसोसिएशन आते हैं, अगर अनलेस वो एसोसिएशन बहुत बहुत स्ट्रांग हो, ऑड्स रेशियो वेरी वेरी हाई विद अ वेरी नैरो कॉन्फिडेंस इंटरवल, तो देन आप कह सकते हैं स्ट्रेंथ ऑफ एसोसिएशन इज हाई। फिर अगेन उसके अंदर जो है कंफाउंडिंग के लिए आपको एडजस्ट करना पड़ता है, एनालिसिस ऑफ कोवेरियंस करना पड़ता है या स्ट्रैटिफिकेशन करना पड़ता है। उसके जरिए यू कैन एडजस्ट द रेजिडुअल कंफाउंडिंग फिर भी रह जाती है, लेकिन यू कैन एडजस्ट उस एसोसिएशन। तो यहाँ पे मतलब इट सीम्स के ऑब्वियसली क्योंकि हमने कुछ स्टेटिस्टिक्स स्किप की, तो स्टेटिस्टिक्स स्किप करने से होता है कि फिर वो जो पूरा पिक्चर वाले लोग जो होते हैं ना, फिर वो कंफ्यूज हो जाते हैं। क्योंकि ऑब्वियसली इसके अंदर जो चीजें दिखाने की कोशिश कर रहे थे हम कि विद इन दैट डेटा एक एसोसिएशन और उसको मल्टीपल लीनियर रिग्रेशन किया उसके अंदर, और टू आइडेंटिफाई जस्ट लाइक अ स्ट्रेट लाइन इक्वेशन डिटर्मिनेंट्स ऑफ व्हाट कॉजेज यूटीआई। सो एक तो ये कि जो डिजाइन है इसके अंदर जो डिजाइन है, क्वेश्चन है बेस्ड एंड मोस्टली लॉट ऑफ रिकॉल बायस, लॉट ऑफ डेटा, मिसिंग डेटा, उसकी जो है एब्सेंस, और ये सारी चीजें ऑलरेडी उसको आउटकम को या आपके जो एसोसिएशन को थोड़ा सा कंफाउंड करेंगे। एक तो ये चीज है। दूसरी चीज ये है कि जब व्हेन दे डिड दैट, देन ऑब्वियसली एक उन्होंने देखने की कोशिश की कि यूटीआई जो एक मेजर आउटकम है, उसके क्या डिटर्मिनेंट्स हैं इन पेशेंट्स हु हैव इंडवेलिंग लॉन्ग टर्म कैथेटर्स। तो वो जब देखने के लिए उन्होंने कहा कि कुछ पेशेंट डिटर्मिनेंट आउटकम्स होंगे, एसोसिएशंस होंगे, और कुछ क्लिनिशियन या नर्स डिटर्मिनेंट एसोसिएशन होंगे। So patient determined association में patient can be complaining of pain, can be complaining of bladder spasm, can be complaining of fever and things like that. But जो nurse associated associations हैं, other things जो वो questionnaire से किसी तरीके से उन्होंने निकाले होंगे, वो कि भी उसमें sediment नजर आ रहा था, उसमें वो dirty था, वो क्या था, bladder के साथ जो है कोई लीक हो रहा था, वो केयर गिवर बता सकता है। तो बहुत सारे डिफरेंट चीजें करके वो they just wanted us to understand so what are the principal factors which are the determinants of UTI in long-term indwelling catheter users? अब उसके अंदर जो internal validity की हम बात कर रहे हैं, internal validity is all about the study design and its integrity. तो study design and its integrity के अंदर अगर if you have in retrospective studies addressed missing data and how you addressed it, what kind of imputations you made for that, how did you address confounding, did you adjust it or do an analysis of covariance, ये सारी चीजें करके, and how well the subject, I mean like the study design का जो खुद का जो integrity है, that is the internal validity even in observational design. फिर जो आप उसकी external validity is all determined by your eligibility criteria. तो आपके जो inclusion criteria जितने broad होंगे उतनी external validity, inclusion criteria जितने narrow उतनी कम external validity, exclusion criteria जितने ज्यादा उतनी कम external validity. तो वो फिर उसमें वो portion आ जाएगा. A study which is not internally valid because of the study design या उसकी integrity ठीक नहीं है, cannot be externally valid. ये बड़ा important चीज है. तो जो भी अगर ये इन्होंने स्टडी की, secondary analysis की, उसकी भी अगर integrity अंदर अच्छी है, क्योंकि पूरा स्टडी पढ़ी नहीं, तो unfair for me to criticize anybody. तो वो किचकी होगी, उसमें regression डाला, ये किया, odds ratio डाले, तो ये फिर उन्होंने वो एक measure of association उसके अंदर determine किया, और odds ratio के अंदर उसमें उन्होंने दिखाया है कि जो इवन जो आप सबसे पहले वाले जो आप डेटा दिखा रहे थे Catheter-Associated UTI के साथ, उसके अंदर भी जो odds ratio also अभी जो measure of association वो actually crossed point of 1, तो 0.99 से लेके कुछ 2.52 था, which meant कि the truth can be anywhere from 0.99 to 2.52. We don't know कि the truth is 0.99 और truth is 2.52. तो वो उसके दरमियान कहीं था, उसके p value significant नहीं थी, वो भी 0.057 थी के नोटिस। तो कहने की बात सारी ये है कि एक सेकेंडरी एनालिसिस करने की कोशिश की गई। सेकेंडरी एनालिसिस को आप टर्शियरी एनालिसिस कर रहे हैं, आप फर्दर उसको क्रिटिक करने की कोशिश कर रहे हैं, तो देन वी शुड बी एबल टू सिफ्ट आउट कि क्या एग्जैक्टली मेथोडोलॉजी थी सेकेंडरी एनालिसिस की। तो क्योंकि सेकेंडरी एनालिसिस के अंदर इसी जो पोस्ट हॉक एनालिसिस के अंदर यू डोंट वांट टू बी गोइंग इनटू अ फिशिंग एक्सपेडिशन, उसके अंदर भी एक ए प्रायोरी हाइपोथेसिस होना पड़ता है कि दिस इज व्हाट वी आर ट्राइंग टू डिटरमिन, दिस इज अ स्टडी क्वेश्चन, उसके बेसिस पे ये चीजें की जाती हैं। बट दीज आर ऑल hypothesis generating and you should be able to design another study to answer the unanswered questions that were unanswered in the randomized control trial, and that this has now further thrown up in the form of anything else where you have a matched group that you'll be able to see, okay, how does the matched group do. So I mean I'm sorry I can't comment on the exact integrity of the study because थोड़ा सा कुछ वो ओवरवेल्म हो गया था कुछ अदर लिटरेचर, तो आई थिंक आई कुडंट गो थ्रू द स्टडी. कब भेजा था हमने? परसों भेजा था, कल भेजा था? अच्छा, हाँ वो दैट्स द थिंग. वो मतलब नहीं कि फिर ये होता है ना कि हमारे कोई और कमिटमेंट्स होते हैं, मसलन कोई टीवी देखना है, कोई ड्रामा आ रहा हो, कुछ हो रहा हो, तो उसको चेंज करना एकदम से एक दिन पहले मुश्किल होता है. लेकिन मतलब मैंने मे बी परहैप्स 3-4 days तो ज्यादा फिर कर सकेंगे. आई एम सॉरी, आई कुडंट रीड इट एक्चुअली. तो इसलिए मुझे जब देख रहा हूँ तो मुझे अभी तक पूरा समझ नहीं आई, टू बी ऑनेस्ट, बट आई जस्ट वांटेड टू गिव सम ओवरऑल. थैंक यू.
So this concludes today's session. Thank you very much for coming.